Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is about OZURDEX, an injectable dexamethasone implant which is used for the management of macular edema due to the branch retinal or central retinal vein occlusion or non-infectious posterior uveitis. This is a patient who has intermediate uveitis because of multiple sclerosis. He has already received treatments by the neurologist for interferons, and he has also history of uveitic glaucoma, for which he has already got treatment, deep sclerectomy, and with mitomycin in the right eye. Pressure was controlled with anti-glaucoma medication, and he had on and off episodes of uveitis flare-up. So he also used topical steroids and cycloplegics. As I mentioned earlier, this patient has multiple sclerosis. So if you see this OCT, he has got macular edema, and there is thickening over there in this, which is shown in the OCT. Another OCT slide. Here you again can see the intraretinal fluids and even subretinal fluid over there in the macular section, causing macular edema, which is causing decreased vision of this patient. OCT of the other eye, no problem, no macular edema, no thickening. The other eye, the right eye, is normal, stable. So it is only a unilateral left eye which was involved. The view was very hazy, so OCT was done. Along with that, B scan was done, and then the B scan you can see over there vitreous diffuse haze over there, inflammation, inflammatory activity going on. So active intermediate uveitis, which can be seen over there, no scleral thickening, but definitely so much activity going on in the B scan. As I mentioned, this is non-infectious uveitis. So one of the treatment modalities available is to give injectable OZURDEX in the eyes of these patients, and it was given to the patient. This patient is pseudophakic, and after 2 months it was observed that the implant has migrated into the anterior chamber. So this is a complication sometimes encountered, which I wanted to discuss with you. It is lying anteriorly, inferiorly in the anterior chamber, and it has possible complications over there. If it is not removed, it can cause to the corneal decompensation, and later on the patient may need the keratoplasty. So this also increases the intraocular pressure. So this is the slit lamp photograph of the patient who was given this injection, and within 2 months it migrated to the anteriorly. So now the question arises, why did this move over there? What are the possible reasons and complications, reasons and risk factors which move this over there? Is it safe in every patient, or we have to take some precautionary measures? So this is the question which we will discuss. Another anterior segment photograph, the cross section, you can see over there, there no activity, no ciliary congestion, eye is quiet, and inferiorly you can still see the implant over there. So as I mentioned earlier, that this is a biodegradable implant, and its size is from rod shaped from 0.46 millimeter to 6 millimeter. It's the sizes, and it releases almost 0.7 milligram of dexamethasone into the eye. The problem occurs when this thing moves into the anterior chamber. This is one of the possible, rare but possible complication, and this usually happens in the eyes which are usually vitrectomized, in which we have put scleral fixation IULs, anterior chamber IULs, Arras-Clarke lenses, or they have PCRs over there, or anyway any anterior face is disturbed over there, maybe zonular defect over there, so it moves over there, can come into the anterior chamber. Now when it's in the anterior chamber, then it's a problem, because it can very rapidly cause the endothelial decompensation. It has to be removed. So it can be removed and managed by different attempts, different techniques have been tried. For example, one is the conservative. People have tried the reverse Trendelenburg position. People dilated and patient stays in that position, reverse Trendelenburg, and once it moves back into position, back into the vitreous, then the patient sits over there and sleeps in 45 degrees until it settles down. This is one way. Other way is if it has to be removed, it is to be removed from the anterior chamber, and the thing is better to use the viscoelastics. Yes, otherwise it will keep on moving with if we keep using fluids, it is difficult. Viscoelastics can be helpful to stabilize, maintain anterior chamber and push it with gradually over there with the paracentesis done over there. Whenever you try to hold it, it will start breaking into the pieces. So gradually it should be taken out from that position with the port. Apart from this, if we talk about its role in controlling the macular edema, it is very effective. Patient does not have to undergo repeated injections. It is once put, it stays there in the vitreous for 6 months and gradually keeps on working over there, decreasing the macular edema. It is FDA approved. So all these are things of beneficial, but these things should be also risk factors, as I told you. The high risk patients and the patients, if these problems are there, as I mentioned, pseudophakic, anterior hyaloid face is compromised. These patients should be warned about the traveling by air, because when you're traveling, there is high pressure in vitreous, which can also contribute to its migration anteriorly. So this is one thing which I wanted to discuss with you. Sometimes it is also very much possible that you put this through the pars plana into the mid-vitreous over there, and it moves forward and gets stuck to the posterior capsule. It can rupture over there and cause the cataract and gets attached to the lens. So in that way, this patient, that cataract has to be removed. And as there is also sometimes a PCR rent over there, so you have to very carefully remove this. Even you can take it out with the phaco. Yes, phaco probe, you can take it out. This implant, which is their part, has become a part of the cataract. And these patients usually to be managed in the same way as we manage the posterior plaque cataracts. Whenever you do hydrodissection, there is posterior capsular rent over there, you find over. So these patients to be managed very carefully. And then you can put 3-piece IOL, or you can put the scleral fixation IOLs. So multiple complications can happen. As I mentioned, migration into the anterior chamber, and it can also cause cataract and become part of the this phakic eye. So this was very interesting case which I wanted to share with you. I hope this will be beneficial for my respected audience. Thank you.